Hi, this is Zach Fulkerson with the Critical Care Curriculum, and this is the second lecture we're going to do in respiratory failure. In this one, we are going to be discussing hypoxemia. So if you haven't looked at the first video, go ahead and take a look at that. That's where we discuss hypercapnia, and this one we're going to be discussing hypoxemia. We're going to use this diagram a lot. So this diagram, we have an airway, we have bronchioles, and we have alveoli. We have a pulmonary vessel, so basically a pulmonary artery or arterial with blood flow coming this way, and another arterial coming this way. They meet together to form a pulmonary venule that's eventually going to go back to the heart. And of course, we have these arteries are delivering carbon dioxide to the alveoli, and they are picking up oxygen from the alveoli. So this diagram is one that we are going to be using extensively during this lecture. So let's get into it. The first reason that we can have hypoxemia is simply because of a low alveolar PO2, or the oxygen in the alveoli is low. There are two main reasons that this can happen. One can be a reduced FiO2. So we're not going to talk about this that much, but basically, if this is small, we have a smaller diffusion gradient to get oxygen from the alveoli into the blood. This is what happens at high altitudes. Now, since we're not going to be seeing high altitude stuff in the ICU all that often, we are not really going to be thinking about this. But there is one other way that we can have a low alveolar PO2, and we discussed it in the last lecture, and that is hypoventilation. So if a patient is hypoventilating, which means they are holding on to excess carbon dioxide, that carbon dioxide will diffuse into the alveolar space. Now, this is a relatively fixed space, and when one gas goes up, another gas has to go down. And so as the carbon dioxide pressure goes up, the oxygen pressure goes down, and you can get hypoxemia. As we discussed in the last lecture, hypoxemia from this is a very late finding, and hopefully you have figured out that the patient is hypercapnic before they have gotten significantly hypoxemic. All right, let's move on. The next thing that we can have is abnormal diffusion. There's two ways that this can happen. The first is a thickened interstitial membrane here. So basically someone with interstitial lung disease might have junk, fibrosis, all sorts of stuff in the interstitium that thickens it and makes it difficult for oxygen to diffuse pass from here to here. The interstitium also gets thickened in pulmonary edema. That's one reason that pulmonary edema causes hypoxemia. So this can be thickened in pulmonary edema. The other reason that we can have poor diffusion is not necessarily because of thickened interstitium itself, but we can have low diffusion because we don't have as much surface area. So if we are losing alveoli because of a loss of surface area, so we don't have an alveolus over here, then we will have reduced diffusion. This is what happens in emphysema. Emphysema, we actually have destruction of lung units from smoking, usually from smoking, and that causes poor diffusion. All right, moving on. Next is probably the most common thing that we see in the ICU, which is VQ mismatch. This can be anything from atelectasis to pneumonia to ARDS. And essentially what's happening is we have something that's plugging up an alveolus over here. And so all of the blood that's going through here is not really picking up a lot of oxygen because we have basically poor ventilation into this alveolus. So that by the time it gets to the pulmonary vein, the oxygenation is going to be low. Again, you can imagine a consolidated pneumonia doing this, but also if we hyperexpand an alveolus, we can get VQ mismatching. ARDS, pulmonary edema, they all cause VQ mismatching. So it is a little bit of a grab bag, and it's the most common thing that we see in the ICU. VQ mismatching taken to its extreme, where we have no ventilation and perfusion, is called a shunt. Shunts can happen both in the heart, an intracardiac shunt, where blood is moving from the right side of the heart to the left side of the heart, completely bypassing the lungs. Or it can happen in the lungs themselves. There are things called AV malformations that can occur. We can also get, we can see those often in people in cirrhotics, where we have pulmonary shunts that tend to happen in the bases of the lungs, and so the shunt fraction tends to be worse when people are sitting up. That is an interesting finding called orthodeoxia. So a cirrhotic patient who's hypoxemic may have a shunt, and you may have a clinical finding of orthodeoxia, where when they sit up, more blood flow goes through the shunt and their shunt fraction increases, so they become more hypoxic and short of breath when they sit up. So these are the main reasons that we can get hypoxic respiratory failure. Let's go to a quick question. In this question, we're going to be talking about PEEP. If you have not taken the ventilatory lecture, you can do that. But real quickly, PEEP stands for positive end expiratory pressure. So we are discussing a patient who's on a ventilator, and we're discussing how much alveolar pressure we're going to put in at the end of expiration. So which of the following types of hypoxemia is not likely to benefit from PEEP, or positive end expiratory pressure? Is it compressive atelectasis due to obesity? Is it a dense lobar consolidation? Is it moderate ARDS? Or is it pulmonary edema? I want you to think about what we have talked about so far and use that to answer your question. So the answer here is a dense lobar consolidation. And to explain this, we are going to go back to our diagram. So here are our answer choices right here. This is our typical diagram. So let's look at compressive atelectasis. If we have compressive atelectasis, then we have alveoli that are essentially completely collapsed. It's not really drawn as collapsed here. This is the best I could do. But we have poor ventilation going in here, and we have normal perfusion. So all of this blood that's being perfused is not picking up a lot of oxygen because these alveoli are collapsed. So if we add on positive end expiratory pressure, we can blow those alveoli back up. That will help our VQ matching, and that will help our oxygenation. So this can help. Pulmonary edema. If we have pulmonary edema, we have fluid sitting both in the interstitial space as well as in the alveoli itself. So let's think about what happens if we add positive end expiratory pressure. Well, we blow up these alveoli and we decrease how much fluid there is relative to the total space of the alveolus, and thus we have a little bit more diffusion room so that oxygen can get from the alveolus to the pulmonary capillary. And the same thing happens in ARDS, except instead of transidative fluid sitting here, we have some sort of exudative fluid that's sitting in the alveolar space. So the same thing happens with moderate ARDS. Finally, let's think about what happens with a dense lobar consolidation. So we're going to go back to this diagram that we looked at before. So we have a lobar consolidation. This is not recruitable at all. Okay, so if I add PEEP, I'm going to selectively blow up this alveolus right here. And notice I have it encroaching on the pulmonary capillaries. This actually happens in real life. You can actually ventilate someone, open someone up so that you are over distending them and compromising blood flow. So if I have compromised blood flow going through here, that means a larger fraction of my blood is going to go through here where it is picking up no oxygen. So in this particular case with a dense lobar consolidation, PEEP has not only not helped me, but it actually has the potential of worsening my hypoxemia by worsening that VQ matching. Okay, so that is how PEEP helps you out in the ICU. It doesn't work for every situation, and so you need to be thinking about what situations does PEEP help you out and what situations it can hurt you. All right, that does it for that. A few more things that we are going to discuss before we call it a day, and that is hypoxemia with a normal chest x-ray. You will see this quite a bit, and it's good to have a nice differential diagnosis. The first thing that you'll remember is hypoventilation. So remember, if I have given someone, say, if someone's overdosed on heroin, or I've given someone too much opiate, they may hypoventilate, their PCO2 goes up and their oxygen goes down. The x-ray looks just fine. Okay, so hypoventilation is the first way that you can get hypoxemia with a normal chest x-ray, and you would find this with an arterial blood gas. Second, a shunt.
We already talked about this. We can have intracardiac shunts or intrapulmonary shunts. You will see an intrapulmonary shunt often on a chest CT, especially if we're talking AV malformations, but often the chest x-ray looks normal. Pulmonary embolism, I have put this in bold because you need to remember this. If you have hypoxemia that you cannot explain, this is the diagnosis to exclude. It causes hypoxemia because of VQ mismatching. Status asthmaticus. Now, this is an interesting one because it causes hypoxemia partially because of hypoventilation, but also partially because the increased alveolar pressure causes worsening VQ mismatching, and so that can lead to hypoxemia. Pulmonary hypertension, we see this in clinic very often. So people who have elevated pulmonary pressures, they have problems with diffusion. They probably also have some VQ mismatching. And pulmonary hypertension you will not see on a chest x-ray. And finally, even though this doesn't have to do with the lungs, we have hemoglobinopathy. So if someone has, say, a methemoglobinemia or carbon monoxide toxicity, this of course will not show up on a chest x-ray. And it's not related to the lungs or the heart per se, but it's related to hemoglobin molecules themselves. Well, that does it for hypoxemia. Hope this lecture has been helpful, both this one as well as the lecture on hypercapnic respiratory failure.